All right. Assalamu alaikum, everyone. I hope you're all doing well. My name is Rawad Turko, and today we're going to be doing the Hem-Onc Crash Course Part 2. This one's going to be more specific to the oncology part, so your leukemias, your lymphomas. So, inshallah, this should, if you've already done your first pass of everything, this is, inshallah, going to be a pretty thorough review of everything that you've been taught. So, just follow along, and I'm going to want it to be a little bit more interactive. So, just try to follow along and ask questions, answer questions whenever you can. Sorry. Okay. So here are the objectives. We're going to be doing bone marrow failure, leukemias and molecular bases of leukemias and lymphomas, myeloproliferative disorders, lymph node disorders, oncological emergencies, and leukopenia and leucocytosis. So let's start. Now, we have pancytopenia and aplastic anemia, and a lot of people get these confused sometimes. So I want you to just get two things clear in your mind. Pancytopenia is a lab finding. So when you look at the labs, when you do a CBC and you find a reduction in all three types of blood cells that are erythrocytes, leukocytes, and platelets, then that tells you that this is pancytopenia. Now, pancytopenia can be a result of many different things. You can have drugs causing pancytopenia. You can have congenital diseases causing pancytopenia. But when we refer to pancytopenia because of destruction of hematopoietic stem cells, or in other words, a lot of the times it'll be bone marrow infiltration, that's when we recognize it as aplastic anemia. So pancytopenia is a lab finding. Aplastic anemia is a type of pancytopenia that's due to a destruction of hematopoietic stem cells. Okay. And all of the clinical findings of pancytopenia are going to be related to the cell lines that are reduced. So if we have reduced erythrocytes, we're going to have anemia. If we have reduced leukocytes, then we're going to be more prone to infection. So there are going to be recurrent infections, or infections that would otherwise be very mild could be very severe in this case. And platelets, we would have thrombocytopenia. And you guys already know from the same block that when you have thrombocytopenia, you might see things like purpura, you might see gum bleeding or epistaxis, or like easy bruising. All these things are pointers to thrombocytopenia. Okay, so these are the clinical presentations. All of them are going to present the same clinically. When we want to determine the cause of the pancytopenia or the aplastic anemia, that's when it gets a little bit more confusing, and we have to focus a little bit more about investigations like history, for example, or history or genetics and karyotyping, things like that. So again, aplastic anemia, it's a failure or destruction of hematopoietic stem cells. There's a lot of different causes. So radiation, viral agents. I want you guys to focus on hepatitis viruses. So those can, pretty commonly cause aplastic anemia. Fanconi anemia, which we're going to talk about in a minute. Um, Idiopathic causes that may be primary, okay, and these mean that they're autoimmune causes. And then drugs that can cause aplastic anemia include things like chloramphenicol, right? Things like anti-epileptics like carbamazepine can cause aplastic anemia, phenytoin, all these things. Okay, now it is it is characterized by a low reticulocyte count, and obviously because you know that your reticulocytes are going to be the ones that are producing all of your red blood cells, and increase erythropoietin. Okay, why is that? Because we have destruction of the hematopoietic stem cells, and your body can sense this anemia. So what it's going to do is it's going to drive up this erythropoietin in order to bring back the red blood cell count back to normal. We also are going to get pancytopenia again, leukopenia and thrombocytopenia. Symptoms, as I already mentioned. Treatments can be things like withdrawal of offending agents. So if it's a drug that's causing the aplastic anemia, we're going to withdraw that drug. You could use immunosuppressive regimens. These are for the idiopathic causes, so causes that are not very clear. We could treat them with drugs that can inhibit the immune response, anti-thymocyte globulin and cyclosporin in particular. Bone marrow allograft, of course, to return the hematopoietic stem cells and to bring up all the reduced cell lines. And we can do bone marrow stimulation too. Okay, so who can tell me which one of these is a bone marrow biopsy or a bone marrow aspiration of a person with aplastic anemia? Is it A, B, C, or D? I'm not sure if I can see. Oh, I can't see the chat. D. Do we have any other options? Okay, D. Great. Can somebody tell me why? It is D. You're right. Why? What are the buzzwords for aplastic anemia that they always say in question stems? Do you know? Okay. Well, it's fatty infiltration. Okay, so you'll see an acellular Yep, fatty deposits, exactly. So you'll see an acellular bone marrow with fatty infiltration. These are buzzwords for aplastic anemia. You'll know immediately that it's aplastic anemia. Perfect. Okay, so the answer is D. All right, who can tell me a diagnosis? So this child has easy bleeding, he has recurrent infections, and he has pallor and pale conjunctiva and pallor. Who can tell me what the diagnosis is? Fanconi. Perfect. So this is, yep, this is Fanconi anemia. Fanconi anemia, again, it's a deficiency of a of a double-stranded DNA repair mechanism, and it's going to be characterized by a lot of things. So you'll see here, it's autosomal recessive DNA repair defect causing bone marrow failure. You'll see short stature, you'll see cafe au lait spots. Okay, and you'll see thumb, problems with the thumb. So you'll either are going to get absent thumbs and radii, or you're going to get polydactyly of the thumb. Okay, so this immediately is going to tell you that it's a Fanconi anemia. Again, it's a defect in DNA repair. So it's a DNA repair mechanism that's been defective. Okay, now you have this child. Okay, this child has this following blood smear, and he has this physical exam finding, and he's presenting with very acute onset aplastic crisis, low RBCs, low white blood cells, low thrombocytopenia. What can cause these findings? What infectious agent can cause these findings? Try to focus on the physical exam findings here. This picture. Parvovirus B19, perfect. So this is a case of aplastic crisis brought on by parvovirus B19 in a child who has sickle cell disease. Again, you can see here that this is sickle cell disease. Again, this is not specific to sickle cell. Any blood cell disorder that has to do with the hemoglobin, so like thalassemias can also predispose to aplastic crisis with a parvovirus B19 infection. Slap cheek, exactly. So this is a characteristic of parvovirus B19 infection. You get the slap cheek fever. Perfect. Okay, so we're gonna refresh very quickly the hematopoietic cell lines and all of their precursors and of their you know the cells that we get from them, because it's going to be very important when we talk about leukemias. So we have a multipotent stem cells that's going to give us a myeloid stem cell and a lymphoid stem cell. The lymphoid stem cells, they're going to give us plasma cells, T helper cells, cytotoxic T cells, and B cells. Okay, so these are the important ones that I want you to focus on. B cells and T cells, we're gonna get that from the lymphoid stem cell. Okay. The myeloid stem cell is gonna give us everything else. So that's the red blood cells, it's going to give us platelets, it's going to give us eosinophils, basophils, neutrophils, and monocytes or macrophages. Okay. Why is this important? Because a lot of people get confused with the leukemias. When we talk about leukemias, they get confused over what's myeloid and what's lymphoid. It's very easy. If you see something that looks like a lymphocyte, like this, it looks like a B cell or a T cell, there are no granules, then 99% of the time is going to be a lymphoid leukemia, either chronic or acute. Okay, but if you see granules, or if you're seeing something in the cytoplasm or bilobed or multinucleated cells, that's most likely going to be a myeloid origin. Okay. Do you have any questions so far about the bone marrow failure? Okay. All right, so these are the leukemias we're going to talk about. We have four kinds. We can split them into lymphocytic and myeloid, and then acute or chronic. Now, the main thing that I want you to know about acute or chronic acute leukemias are going to be, first of all, they're going to be very acute onset, okay? They're going to be very quick onset, rapidly progressive, and you're going to see them in children, and you're going to see that children with acute leukemias, usually they have better prognosis than adults with acute leukemias, okay? Now, chronic, and another big difference between acute and chronic leukemias is that with acute leukemias, you're going to have the precursor cells that are more apparent. What's another name for them? What's the cutoff line for these precursor cells, and what do we call them? It's like a buzzword for an acute leukemia. The word is blasts. So the cutoff is, yep, blast. The cutoff is 20% blasts in the bone marrow. If you see 20% blasts in the bone marrow, immediately you'll know that this is an acute leukemia. Okay, now whether or not it is lymphocytic or myeloid in origin, we're going to talk about in a minute. Okay, so we're going to go into detail over every single one of these in a minute. So who can tell me what the diagnosis is here? Just to help you out, in this case, it's a child presenting with easy bleeding, irritability, and whenever his mother tries to touch his thighs or his legs or any long bones, then you're going to get a lot of pain. The child's going to be very irritable. Correct. So this is acute lymphoblastic leukemia. Perfect. What gave it away? What's the main thing that I said? The first thing that I said that immediately gave it away, it's the children. So what's the affected age group? The affected age group is usually children. Most of the time in a question stem with ALL as the answer, it's going to be a child, 100%. Now, what is the feared organ involvement? Now, if this organ is involved, that tells you that this leukemia is progressing and that, we're going to have to step in. CNS and what's the other one? CNS and there's two. And testes, perfect. So CNS and testes are two organs that can be involved in acute lymphoblastic leukemia. Once they're involved, we know that there's some trouble there. Okay. Poor prognostic factors. Who can tell me some poor prognostic factors? Okay. Exactly. Yeah. So we have the hypodiploid karyotype. We have these translocations 1719. 922 is going to be repeated a lot in poor prognostic factors. This is because 922 is the Philadelphia chromosome and also the T cell subtype. Now, the T cell subtype of acute lymphoblastic leukemia, you could also have some thymus involvement in T cell subtype of leukemia. So if you get a T, and most likely the T cell subtype is going to be more apparent in children of like teenage age. So if you get a teenager who has some thymus involvement and then symptoms of an acute lymphoblastic leukemia, you'll know this is ALL with probably a poorer prognosis than other subtypes. Okay, so again, so this is acute lymphoblastic leukemia. It's the most common cancer in children. Common clinical manifestations include bleeding and easy bruising. Bone pain is very, very important. And you could also see hepatosplenomegaly, okay? Because again, since you have this bone marrow infiltration, you're gonna have the symptoms of anemia and everything. That means there's not enough red blood cells, there's not enough red blood cells in the bloodstream. And so these secondary organs that are going to try to proliferate or they're going to try to bring the red blood cell count back up is the liver and the spleen. Okay, so you're gonna have some hepatosplenomegaly. And as always, as you guys know, I love to do this thing. Um, I love to add vignettes in all of my questions or in all of my pals because I think it's very good in order for you to see how they actually give you a case of ALL in an actual question stem. So I think I got this question from Robbins. So let's just read it. A 7-year-old boy has complained of a severe headache for the past week. So there's some CNS involvement there, as we mentioned. Okay. On physical examination, there is tenderness on palpation of long bones, hepatosplenomegaly, and generalized lymphadenopathy. Petechial hemorrhages are present on the skin. Lab findings show low hemoglobin, low hematocrit, low platelets, low WBCs. A bone marrow biopsy specimen shows 100% cellularity with almost complete replacement by a population of large cells with scant cytoplasm lacking granules. This is it. As soon as we see lacking granules and delicate nuclear chromatin, we know that it's ALL. And in a patient, in a small child who has also bone pain, that's ALL. Okay, so here are the buzzwords that they always repeat over and over. As soon as you see any of these, it's a pretty strong indicator of ALL. So a child with bone pain and bruising, refusing to bear weight, obviously because of the bone pain, large mediastinal mass on chest X-ray. Again, this is more specific for the T cell subtype and more in teenagers. Positive TDT. Now, TDT is something that you see in lymphoid precursors. So lymphoblastic cells are going to have TDT. It's a type of DNA polymerase. You just have to know that it's present in lymphoblastic cells. Okay. Again, lymphoblasts with high nuclear to cytoplasmic ratio and testicular or CNS involvement. All right. And here are the pictures. Here are a few pictures of acute lymphoblastic leukemia. Again, we see that there's no granules. We see that there's very scant cytoplasm. It's not very apparent, and we can't really see the nucleoli all that well. Okay, so these look like lymphocytes that are a little bit weird. They don't look like myeloid cells. So that's how you know that it's an acute lymphoblastic leukemia. Now, who can tell me what the diagnosis is here? And zoom in. Look at it very carefully. Look at this thing. Look at this thing. This thing. What is this? Perfect. Inshallah. Perfect. So this is AML. This is acute myeloid leukemia. Okay. Now, who can tell me what these things are called? These cytoplasmic inclusions. What are they called? Hour rods. Great. And what are they made up of? Do you know what they're made up of? These hour rods? Myeloperoxidase. Perfect. So these are our rods made up of myeloperoxidase. Now, myeloperoxidase, as you guys might remember from, I think, either either year one or year two, I'm not sure. But myeloperoxidase is an enzyme that neutrophils use in order to, once they phagocytose the antigens or the cells, they're going to release this myeloperoxidase to kill whatever's inside the cell. Okay. Now, who can tell me one subtype of AML that has a favorable outcome, but a very but also they are associated with a very yep, a very high risk complication? Yeah, that's APML, acute promyelocytic leukemia. Perfect. Yeah. Okay, poor prognostic factors. Who can tell me? Okay. So deletion of the 5 chromosome, translocation again Philadelphia chromosome, and translocation 9 to 11. These are just things that you have to remember. Also, do go back and try to remember a few of the good prognostic factors. I know that for ALL there was, or sorry, yeah, ALL there was 1221, translocation 1221. So some of these are very important. The one that I want you to remember most is 1221 for good prognostic factors. Okay. Okay. Now, again, subtype of the previous, we know that this is acute. Oh, sorry. We know that this is acute promyelocytic leukemia. What gives it away though? What gives it away? The fact that it's acute promyelocytic leukemia. Multiple hour rods. Perfect. So the hour rods, they're very, very, very highly associated with APML. Okay. So the mutation, as our colleague just mentioned, that it's a translocation of 15 to 17 that's going to produce this fusion protein, APL dash RARA. This is going to be a transcription factor and is going to produce a lot of, it's going to cause the cell to be highly proliferative. Okay. What's a feared complication of APML? DIC. Perfect. Now, who knows why? Who knows why APML is very associated with DIC? It's because these hour rods in here, once they're released into the bloodstream, once these cells sort of die off and they release all of these granules into the bloodstream, they're gonna set off these antithrombic factors that's gonna cause the coagulopathy that's seen in DIC. Okay, what about the treatment? Yep. ATRA, all trans retinoic acid, and arsenic. You don't have to know arsenic, you just have to know ATRA. Okay, perfect. So again, AML, commonly occurring in adults. Okay, so it's not necessarily a child, but again, they're always going to say something about the myeloperoxidase, or they're going to see something about the hour rods. So here's the vignette. A 34-year-old man has experienced multiple nosebleeds along with bleeding gums for the past months. So thrombocytopenia. On examination, his temperature is 37.3. He has multiple cutaneous ecchymosis, lab findings, blah, 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 blah. 5% segmented neutrophils, 5% bands, 2% myelocytes, 83% blasts, so it's acute, 3% lymphocytes, and 2% monocytes. You see how it's mixed? So there are some neutrophils, there are some lymphocytes, there's some monocytes. So examination of his peripheral blood smears show the blasts have delicate nuclear chromatin along with fine cytoplasmic azurophilic granules. Azurophilic means blue, by the way. When they say azurophilic granules, that's a buzzword. Immediately you know that they're our rods. and these blasts are CD33 positive. So again, these are the hour rods. You'll see them here more clearly, but you can't see them here. See, here's one hour rod. There's a bunch of hour rods in here. And here are some buzzwords. So you'll get an older adult. They might say hour rods or they might say eosinophilic granules in blasts. They might say MPO positive, so they don't necessarily have to say hour rods. If they say myeloperoxidase positive, that means that there are hour rods in here. Okay, over 20% myeloblast and DIC. So if you get a patient who has severe bleeding and they have an IV line and there's bleeding around this IV line, then then that's a pretty, that's pointing you towards DIC. Okay, what about this? Who can tell me this? Here you're gonna have an older patient with basophilia, a lot of basophils, many different basophils. Who can tell me what the diagnosis is? CML. Okay, perfect. So what's the affected age group? Elderly patients. Great. So older adults, 45 to 85. The mutation, classic. We've talked about it 100 times. We're probably going to talk about it 100 times more. Okay, that's Philadelphia chromosome, BCR-ABL, which is a tyrosine kinase. So once you get translocation of the BCR protein to right next to the ABL, ABL is a tyrosine kinase. So what's going to happen is that the BCR-ABL is going to be highly, phosphorylating all these downstream signals, and because of that, you're going to get hyperproliferation. So that's the Philadelphia chromosome. It's a tyrosine kinase. Okay, what can it progress to? CML can progress to acute leukemias. Yeah. So it can progress to both AML and ALL. What do you think it's more likely to progress to? AML or ALL? So the answer is AML. Yeah. So it's AML. 77% of cases that progress are going to progress to acute myeloid leukemia and 33% to ALL, acute lymphocytic. Okay. And what's the treatment? The treatment are any inhibitors of the Philadelphia chromosome. So you can get imatinib, that's the one that's most commonly asked about, I think, and then the rest of these. So ponatinib, nilotinib, and dasatinib. Okay. All right, so again, CML. A 42-year-old man presents with 3 months of fatigue, early satiety, and unintentional weight loss. Exam markedly enlarged spleen, so some splenomegaly there. WBC count of all stages of granulocytic precursors, along with basophilia and eosinophilia. Basophilia, it's very important for CML. Okay, like basophilia alone is extremely rare. It's very rare to see increased levels of basophils in any other infection or anything like that. It's pretty, it points you towards CML pretty accurately if you see it in a question stem. Hemoglobin is mildly decreased and platelets are elevated. Peripheral smear shows a left shift with a full spectrum of myeloid maturation. So again, this is what it looks like. You see granulocytic cells here. You see hypersegmented, so they're not just lymphocytes. You see cells of different shapes and kinds. Okay, and it's an elderly patient too. Okay, and some buzzwords: middle-aged adult, marked leukocytosis, left shift with all granulocyte precursors. Basophilia is very important, and splenomegaly. Now, who can name the three phases of CML and how to differentiate between them? Hmm. Yeah, perfect. So we have the accelerated phase, we have the blast crisis, and we have the blast phase. Okay, or the chronic phase. So again, anything from 10 to 19% is going to be an accelerated phase. Okay, and then greater than 20%, that's going to be the blast crisis. Okay, and then the chronic phase is below 10%. Now, how do you monitor the response of chemotherapy for CML? You're going to look at three things. You're going to look at the hematological remission. cytogenic remission, and molecular remission. Now, we got a question on this, so I really, really do highly recommend that you try to memorize this. Molecular remission, you're going to see a 3 log reduction of the Philadelphia chromosome. In cytogenic remission, you're not going to see the Philadelphia, or sorry, the molecular remission is for BCR-ABL. The Philadelphia chromosome, you're not going to be able to detect it in the bone marrow. That's how you get the complete remission. And normal WBC count for the hematological remission. But remember the 3 log reduction for the molecular remission. Okay. All right. Now, there's a big difference between something called the leukemoid reaction and CML. Now, leukemoid reaction is just reactive neutrophilia that you can get in almost any sort of infection, okay? But it's a little bit hard to differentiate between the two of them because CML can also present as neutrophilia that's being very, very high. So how do you tell the difference? The difference is the LAP score. So the leukocyte alkaline phosphatase score. And CML is going to be decreased. That's because leukocyte alkaline phosphatase is an enzyme that you only see in mature neutrophils. So mature neutrophils have this LAP enzyme that's able to break down all of the pathogens. So that's why in leukemoid reactions, either going to be normal or increased, the LAP score, because I have seen questions where it's normal. But CML, it's almost always going to be decreased, and that's because they're immature neutrophils. So you're not going to be able to see the enzymes of a mature neutrophil. Okay. Now, a few things. This is from your molecular basis lecture that I want you to focus on. Now, I think I can summarize this lecture pretty much in just 2 slides. The rest of it is pretty much all memorization that you have to just, try to go through on your own. Basically, any of these diseases here, you're going to see these mutations. All of them are tyrosine kinases. So this is why I mentioned before that the Philadelphia chromosome is a tyrosine kinase. I want you to remember pretty much 2 main ones. So that's CML associated with the Philadelphia chromosome BCR-ABL. And I want you to remember this one, systemic mastocytosis. That's associated with the c-KIT tyrosine kinase mutation. Okay. The rest of these you can also try to memorize as best to your ability. But I would just say just focus on these two. This one's also very important, but we're going to talk about it hopefully in the next lecture. This is polycythemia vera and essential thrombocythemia, okay, associated with a JAK2 um, mutation. Okay. So just try to remember c-KIT for systemic mastocytosis. Okay. Who can tell me the diagnosis? Here you have an elderly patient, and then you take a peripheral blood smear, you see this, and then you do a bone marrow aspiration, you see this, and he has this physical exam finding. Great. Yeah. Good. Myelofibrosis. Who can tell me what is secreted what is secreted from what cells that causes myelofibrosis? Does anyone know? Okay. That's okay. The answer is n not exactly. The thing that's secreted is TGF beta, transforming growth factor beta, secreted from platelets. That's going to cause the myelofibrosis. Okay, so the TGF beta is going to cause all these cells, macrophages, and so on to secrete and to lay down scar tissue and fibrin and reticulin. All of that's going to cause fibrosis of the bone marrow. Who can tell me what's one very pathognomonic uh, red blood cell finding seen in myelofibrosis? What do the red blood cells look like in myelofibrosis? Teardrop cells, perfect. So you get teardrop cells, and that's because these cells are being squeezed out of the bone marrow, and it's not sufficient enough. So you get these teardrop cells because of the squeezing, and you're gonna get severe hepatosplenomegaly, very, very large hepatosplenomegaly because of the insufficient hematopoiesis. Okay. Oh, so there's a bit of a problem in the next slide, but it's okay. We'll go through it. So the diagnosis, who can tell me the diagnosis here? This is a person who took a shower, took a very hot shower, and felt super itchy afterwards. Pruritus, polycythemia vera. Perfect. So this case of a patient having, it's a classic presentation. Hot shower and then pruritus, classic presentation for a polycythemia vera. The mutation, as you guys know, it's JAK2. A lot of these myeloproliferative diseases that we're going to talk about soon are JAK2 mutations. The erythropoietin levels would be decreased, okay? And that's because the primary defect here is in the red blood cells themselves. So there's going to be, it's not, the problem isn't increased erythropoietin. This would be a secondary polycythemia. But polycythemia vera reveals to a primary defect in the red blood cells. Complications are anything that relates to the increased viscosity of the blood. So because of the polycythemia vera, you're going to have a lot of red blood cells, very, very high hematocrit. So the blood's going to be very slow, it's going to stick together, clump together, and because of that, you could get thromboses and pulmonary embolisms and DVTs, or you could get gouts, gout because of the high turnover rate of all the red blood cells. And as you guys know, red blood cells only have a lifespan of about 120 days. So once these cells die, they're going to release a lot of uric acid. Okay. Treatments, you can get phlebotomies, which are just recurrent. You're gonna uh, they're gonna take blood from you basically. You could donate blood or whatever. Hydroxyurea and ruxolitinib. So ruxolitinib is an anti-JAK2 inhibitor. And once you give this one, this actually would work well for a lot of these myeloproliferative disorders. Okay. So again, myeloproliferative these diseases, we have three main kinds of them, and including CML. So CML is another kind of myeloproliferative disease. Okay. So we have polycythemia vera. So this is primary polycythemia, too many red blood cells because of a JAK2 mutation. As you guys know, as you guys can see here, sorry, uh, three out of the four myeloproliferative neoplasms are associated with JAK2 mutations. The only one that isn't is CML, and that's because it's obviously Philadelphia chromosome is the main defect there. You can get an intense itching after the shower, aquagenic pruritus, erythromelalgia, so severe burning pain and red blue discoloration. You could also get facial plethora. So you'll see the buzzword facial plethora in the question stems. That just basically means that their face, it's very, very red and it looks like they are holding on to a lot of fluid in the face. And it'll appear red due to episodic blood clots in the vessels of the extremities, hyperviscosity, and thrombosis. Okay. Essential thrombocythemia, it's massive proliferation of megakaryocytes and platelets. Symptoms include bleeding, thrombosis, obviously is going to be related to the increased number of platelets. Blood smears show markedly increased number of platelets, which may be large or otherwise abnormally formed, and you can get the same sort of symptoms with polycythemia. Myelofibrosis is, I think, the most high yield one out of the three. You're going to get, again, megakaryocyte hyperplasia that are going to secrete TGF beta, transforming growth factor beta, increasing the activity of the fibroblasts and obliteration of the bone marrow with fibrosis. Okay, you're going to get teardrop cells, massive splenomegaly, and you're going to see this picture. Okay, so this is a pretty fibrotic bone marrow. Okay, so now we're going to move on probably to the heaviest part of the crash course, which are lymph node disorders. Before we get into all of the actual disorders, we're going to just take a minute and review some of the anatomy. So here we have a follicle. This is known, by the way, as a secondary lymphatic tissue. So the main ones are the thymus and the bone marrow. These are secondary. This is where all of your immune responses occur. So it's split into three parts. There's the medulla here, there's the cortex, and then there's the paracortex. The cortex are where you're going to see your B cells. So you're going to see them here. You can see them in two things. You can either see them in primary follicles, which are quiescent. There's not a lot of activity going on in the primary follicle, or you're going to see them in the secondary follicle. The secondary follicle is where you're going to see all the activity of the B cells. Now, the secondary follicle has this thing called the germinal center. The germinal center is where you're going to get a lot of the B cells proliferation during an active infection. Then you're going to see the mantle zone right outside of the secondary follicle. Okay. And in cases of pretty chronic immune activation, there's actually a third zone that's called the marginal zone that we're going to discuss later on. This is important for when we come to the actual disorders. The paracortex are where you're going to see your T cells. So any infection with like viruses or fungi or anything that requires cell-mediated immunity, which you know is your T cells, you're going to get basically hyperplasia of the T cells inside of the paracortex. It's called paracortical hyperplasia. Okay, so this is for T cells. And finally, you have your medulla here. Okay, and that's when you see that's where you have your sinus histiocytes. Okay. So again, this is another picture just to refresh your memory. Secondary follicle, and inside of it, you're going to see a germinal center. You're going to see outside of this germinal center, you're going to see the mantle zone, and then again the marginal zone, and very, very severe cases of immune activation. Okay, so now you have a patient who just has, strep throat. He recently, he had strep throat, and you take a biopsy of his cervical lymph node, and you see this. What is this? This is normal, by the way. Okay. So the answer here is, yep. So the answer here is follicular hyperplasia. Okay, so you guys see these follicles that I talked about before. Again, you have your follicles here. This is your paracortex. These are your sinus histiocytes. Okay. When you see this, when you see something that looks like this, you know that there's an active infection going on, okay? And the reason why I wanted to show you this is because we're going to use this picture and, you know, compare it to a disease we're going to talk about later on. But I want you to notice a few things. First of all, you see polyclonality. You see a lot of different cells of many different colors and shapes inside of these germinal centers. So it's not all uniform. It doesn't all look the same. Okay, so there are different colors in there. And you see these white spots. Now, these white spots are things that are called tingible body macrophages. Now, you guys know when your body is fighting off some sort of infection, you're gonna see these cells, these immune cells that are gonna take up that pathogen, bring it back to the lymphocyte, and then it's going to undergo apoptosis. Okay. Now, what's the result of any cell death, of any apoptosis that happens? What are you going to get? You're going to get macrophage infiltration, and you're going to have uptake of these dead cells. These white things that you see, these white dots that you see, are called tingible body macrophages that are going in and they're taking up and they're engulfing all of these dead immune cells. Okay, this is very important because it's going to be missing in a disease that we're going to talk about later on. Another thing that I want you to focus on is that all of the all of the germinal centers are exactly where they're supposed to be, which are in the cortex, okay? So there's no disruption of the architecture of the lymph node at all, okay? Now, lymphadenopathy, again, when we talk about lymph nodes, so this is normal, these are normal lymph nodes here. When we talk about lymphadenopathy, we're referring to basically anything that can cause pathology in the lymph nodes. It can either be primary, and it's primary in cases of lymphoma, for example, or things that are actually wrong with the lymph node itself, or it can be secondary to any infection or any sort of immune process that's going on in the body. Okay. And once you have inflammation or an active infection or inflammation going on inside of the lymph nodes, we call that lymphadenitis. Okay. Now, acute lymphadenitis, which is usually occurring because of an ongoing infection, like in this patient that we talked about here, the lymph node itself is going to be tender and it's going to be painful, and sometimes it's going to be draining an active infection, and you're going to see exudate and neutrophil infiltrates. Okay. This is a good sign. That means that all it is that our body is fighting off some sort of infection. And because of that, all of these immune cells, they're going in and they're occupying the space in the lymph node. And you're going to get acute lymphadenitis, which is tender and painful. Now, if it's painless, this is where it's a bit more complicated, and there's a higher risk of malignancy, especially in older patients. Okay, when an older patient has painless lymphadenopathy or lymphadenitis, then that does raise a few red flags. So this is the main point that I want you to get from here. In painful lymphadenitis, it's not because of any primary reason. It's usually just because it's draining an active infection. Okay. Who can tell me what the diagnosis is here, by the way? So you have a little kitten here, very cute, and then you're gonna get this presentation. So this is axillary lymphadenopathy. You guys see the lymph node here is enlarged. This looks like a scratch. What is this? Cat scratch. Yeah. So this is cat scratch fever caused by, who can tell me the organism? Bartonella. Perfect. What type of inflammation is seen inside of these lymph nodes? Okay, so the answer is granulomatous inflammation. So you're going to see granulomas, which are multinucleated giant cells. And the buzzword that I want you to know is stellate granuloma. So stellate granuloma, you can also, pretty much point quickly to cat scratch fever when you see this on a question stem. The most common locations of the lymphadenopathy, you're going to see either cervical or axillary lymphadenopathy. Now, the axillary lymphadenopathy is actually, it's not specific. Obviously, it's a cat scratch fever, but you rarely see it in any of these other diseases that we're going to talk about today. So as soon as you see axillary lymphadenopathy, your mind, it should consider at least cat scratch fever. Does anyone know the treatment? Oh, does anyone know the treatment of cat scratch fever? So the answer is erythromycin. Okay. So what's the diagnosis here? So this is a 19-year-old college student who just returned from visiting his girlfriend. EBV. Perfect. So this is specifically infectious mononucleosis that could be caused by EBV. I don't want you to get too confused. Infectious mononucleosis could be caused by EBV, which is the most common cause, or it could be caused by CMV. It could be caused by a lot of different viruses and infectious pathogens. Okay, but you're right. The most causative organism, most commonly is Epstein-Barr virus, EBV. Okay, what type of cells are these? What do we call these? And what origin are they? And of what origin are they? Reactive CD8. Yep. So they're called atypical lymphocytes that are CD8 positive. They are reactive lymphocytes because in EBV, or sorry, in infectious mononucleosis, you're going to get something called reactive lymphocytosis. And when you do a peripheral blood smear and you look at these cells, they're going to look like this. So you'll see they have a weird shape to them. Their nucleus isn't typical of a normal lymphocyte. These are called atypical lymphocytes, okay? What's a risk factor? I think I hinted at this with the case that I just gave you. What's a major risk factor? Kissing. Perfect. So close personal contact or kissing. And that's because this is called the kissing disease. And a lot of the times it's actually going to be reflected in the question stem. So you're going to get, just like I said, a college patient, or sorry, a patient who's of college student age. And they'll tell you a lot of the times that they just visited a girlfriend, for example, or they just visited home or whatever. But a lot of the times it will be a college student. So you're gonna see sore throat. You're gonna see this pharyngitis. You're gonna see very, very, very severe splenomegaly, and that's very important for a reason that I'll talk about soon. Okay, what are the antibodies slash tests that's done in infectious mononucleosis? Monospot. Yeah, so that's the monospot test. And what are the antibodies seen? They're the heterophile antibodies. Okay, so basically what happens in infectious mononucleosis is that for some weird reason, this disease is going to basically cause our immune cells to secrete antibodies against red blood cells of other species. So what they'll do is they'll basically infuse a sample of the patient's blood. They'll infuse it with some sheep blood or some horse blood. And what they'll see is that it'll actually agglutinate and it'll cause hemolysis of these sheep RBCs and the horse RBCs. That's called the monospot tests, and the antibodies are called heterophile antibodies. Okay. Now, what is another cause of infectious mononucleosis that has a negative monospot test? CMV, perfect. So just like I mentioned, it doesn't have to be necessarily just be caused by EBV. It can be caused by CMV, and when it's caused by CMV, you're gonna get a monospot negative mononucleosis. Okay. So again, this is the vignette that it's most likely pointing towards infection mononucleosis. So a 23-year-old, again, younger patient, previously healthy man, has experienced malaise and a low-grade fever and sore throat for 2 weeks. On physical exam, blah, 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 pharyngeal erythema without exudation. There is tender cervical, axillary, and inguinal lymphadenopathy. Laboratory studies show hemoglobin 12.2, hematocrit, blah, blah, blah. Okay. So again, younger patient, sore throat, fever, fatigue, lymphadenopathy. Now, the cervical is what I want you to focus on because a lot of the times with EBV or with mononucleosis caused by EBV, it's going to be posterior cervical lymphadenopathy. Okay. Atypical lymphocytes is another buzzword. Splenomegaly, so you would avoid contact sports. Why? What are we scared of? Why do we avoid contact sports for like a month after your symptoms die off from your mononucleosis? Splenic rupture. Again, the splenomegaly that you see in mononucleosis, it can persist after the symptoms resolve. So because of that, we want to avoid any contact sports for fear of splenic rupture, which can cause, pretty severe hemorrhage and death, actually. So positive heterophile antibodies, so monospot tests, sometimes they could say agglutinate with horse RBCs or sheep RBCs. That's also mononucleosis. And a maculopapular rash after ampicillin. If you give ampicillin and then you see maculopapular rash in a patient with all of these symptoms, then it could also point towards mononucleosis. Okay. So again, fever, hepatosplenomegaly associated with lymphomas. So it could be associated with, or sorry, this is for EBV. Okay, but I just want you to focus on this part here. So avoid contact sports until resolution due to risk of splenic rupture. Okay, and these are the atypical lymphocytes that we see. Okay, again, for EBV, you might get a question that has some antibodies. And if you do, this is just a very helpful table. I took it from your slides, and if you understand this, then you probably will understand enough to solve the question. So we have three different kinds of antigens. We have the VCA, the viral capsular antigen. We have the EBNA, which is the Epstein-Barr virus nuclear antigen, and we have the early antigen that I didn't add here. So if they're all negative, then we know that there's no immunity. This patient has never had EBV or anything like that. Now, if the IgM portion of the viral capsular antigen is positive and everything else is negative, that means it's a very, very early acute infection because the IgG only goes up after a certain period of time. Or it could be non-specific and you might have to do some further testing, okay? But if both are positive IgM and IgG, and IgG for EBNA is negative, then it's an acute infection. If EBNA is positive and the IgM VCA is negative, then that means that this is a past infection because both of these are going to persist for your lifetime. You'll know that IgM is it's an acute phase immunoglobulin, and IgG is more chronic. So if you get IgG positive of VCA and EBNA, you'll know that it's a past infection. Okay. Anything else, you'll probably need some further testing. Okay, but this should be enough for you to answer your question. Okay. Now, before we go into the rest of our lymph node disorders, first of all, does anyone have any questions so far before we move on? Okay, perfect. Before we move on, I just want you to remember a few of these very, very important cell markers. So CD1 to CD1, 3, 4, and 5. 5 is the one that I want you to focus on the most. And 8s are going to be primarily T cell associated. You could see CD5 in some small subset of B cells, just like we'll see later on in one of the cancers. But pretty much all of the time, these are going to be specific to T cells. Okay, B cells are going to be your CD10, 19, 20, 21, 23. 21 is the EBV receptor. So once the Epstein-Barr virus were to enter any of your B cells, it would do so using the CD21 cell surface receptor. Okay, CD10 you would only see in germinal center B cells. Again, you remember we talked about there's germinal center, and then there's the mantle zone, and then sometimes there's the marginal zone. So you're only going to see CD10 in germinal center B cells. Okay, CD19 and 20, you're pretty much going to see them in all mature B cells. Okay, but not plasma cells. CD33, they're myeloid progenitors and monocytes. Okay, remember our question, our sorry, our vignette for I think AML was positive for CD33. Okay, so that's myeloid progenitors. CD16 and 56 are for NK cells. 30, CD30 is for Reed-Sternberg cells, which we're going to talk about in a minute, in addition to CD15. Okay, two more things that I want you to remember. Again, we put here the Reed-Sternberg cells, TDT, which is for lymphoblasts. So again, cells that have lymphoid origin, they're going to be, or lymphoblasts. So these are not for mature lymphocytes, just lymphoblasts. They're going to be positive for TDT. Okay, so now before we go into sorry, before we go into the rest of our disorders, we're just going to take a minute to try to differentiate between a Hodgkin's lymphoma and a non-Hodgkin's lymphoma. Okay, so we've done all of the secondary causes of lymphadenopathy and lymphadenitis. Now we're going to go into the primary causes, which are lymphomas. We can split them into Hodgkin's and non-Hodgkin's lymphoma. Okay, so non-Hodgkin's lymphoma, I just want you to remember that they're mainly, most of the time, they're going to be associated with a worse prognosis than a Hodgkin's lymphoma. Okay, so there's more frequent involvement in multiple peripheral nodes. You're going to get the non-contiguous contiguous spread, which means it's not going to go from just one lymph node to the subsequent lymph node, like in your anatomy. It could just go all over the place. Okay. It will involve your mesenteric nodes and your Waldeyer ring. Your Waldeyer ring is basically a number of lymphoid tissue that you're going to have basically in the tonsils and in the back of your oropharynx. Okay, so it's going to it's going to form a ring, and if you get involvement of any of these lymph tissue, then you know that it's non-Hodgkin's lymphoma because your Hodgkin's lymphoma typically does not involve your Waldeyer ring or your mesenteric nodes, and you could have extranodal involvement. Okay. Now, non-Hodgkin's lymphoma, a lot of the time, it's going to actually be cancers in either B cells or T cells themselves. But with Hodgkin's lymphoma, there is a cell that is the cause of all of your symptoms. This cell is going to release cytokines, which are going to recruit more reactive lymphocytes and reactive cells that are going to collectively cause a mass, or they're going to form a mass together. But the main defect, or sorry, the main cancer is in these specific types of cells in Hodgkin's lymphoma. Who knows what these cells are called in Hodgkin's lymphoma that are going to secrete lymphocytes, or sorry, secrete cytokines that are going to recruit more cells and form this mass. Reed-Sternberg cells, perfect. So again, your Hodgkin's lymphoma, the primary cause of the lymphoma are the Reed-Sternberg cells, but in non-Hodgkin's lymphoma, the primary cause is in the actual, there's a problem, there's some sort of translocation, mutation in the actual B cells or the T cells. Okay? Okay. Who can tell me what the diagnosis is here? So this is a patient who has had um, painless lymphadenopathy. He gets these swollen nodules that will shrink and then go back, or sorry, they will enlarge and then they'll shrink again, and then they'll enlarge and they'll shrink again. Okay, so what's the answer? Follicular lymphoma. Perfect. So first of all, before we get into this, who can tell me what the best way is to biopsy a lymph node? This is very important. Excision. Yeah, so you would just take out the whole lymph node and then biopsy it. Perfect. So what's the translocation associated with follicular lymphoma? 14, 18. Perfect. And what does that cause? This causes an overexpression of what? Perfect. BCL2. Do you guys remember what BCL2 from POD? BCL2 is it's basically something that's going to maintain the structure and the membrane of the mitochondria in order to prevent secretion of cytochrome C. Cytochrome C, you guys can know, it's a pro-apoptotic signal that tells the cell when to die. So if you have overexpression of BCL2, that means a lot of these cells that are in the germinal center, again, this is germinal center cells, a lot of these cells are not going to die. They're going to be anti-apoptotic. Okay. So because these cells, you'll see that they're germinal center cells. What are the cell markers associated with follicular lymphoma? CD20. Perfect. So CD20, CD10, BCL2, and BCL6. BCL6 is also seen in another cancer that we'll talk about in a minute. Not CD5. Somebody said CD5. It's actually not CD5. Do you remember why it was CD10? CD10, and that's because they're germinal center B cells. They're actually not seen, CD5 is not seen with follicular lymphoma. It's seen with another type of lymphoma that we'll talk about later on. Okay. But again, CD20 and 19, obviously, because it's a B cell. CD10 because it's a germinal center B cell. Okay. And this also goes for BCL6. So BCL2, obviously, because you have the overexpression because of the 14-18 translocation. But BCL6 is another cell marker that's only for uh, B cells of germinal center origin. Okay. So perfect. Who can tell me a buzzword associated with follicular lymphoma, usually having to do with the clinical manifestation of this disease? They'll say something. Blank, blank, lymphadenopathy. Waxing and waning. Perfect. Which means that these lymph nodes are going to be enlarged and then they're going to shrink again. So that's waxing and waning lymphadenopathy, painless. That's associated with. Okay. Now, do you guys see the difference here between follicular lymphoma and follicular hyperplasia? Remember the tingible body macrophages that I talked about before, these white spots? We don't see these here. And obviously, because these cells are anti-apoptotic, there's overexpression of anti-apoptotic BCL2, which is going to prevent them from dying, and then you're not going to get the macrophages that are going to infiltrate and engulf all of these apoptotic parts. So no tingible body macrophages. You'll also see that they're monoclonal. So it's all one color. There's not many different kinds of cells inside of the germinal center. And also there's going to be disruption of the normal architecture of the lymph node. Okay? Now, what is this? This is an older patient presenting with something that looks like this. Very, very small lymphocytes, SLL. Or what's another name for it? SLL. CLL, perfect. CLL once it actually enters the bloodstream. There's a reason that I didn't mention chronic lymphocytic leukemia earlier when I was talking about leukemias, and that's because I wanted to actually talk about it here. So, what is the affected age group? We already said that it's going to be in elderly patients. Okay. Again, these are small lymphocytic cells. So, a few buzzwords that you're going to get in your question stem are very small cells, elderly patients. Usually they're associated with a poorer prognosis because they're coming on very, very late in disease progression. Um, okay. This is an older answer, so ignore this. Okay. What are the cell markers associated with CLL, SLL? CD20 and CD5. Perfect. So CD20 and CD5 are what you're going to see here. That's how you differentiate it with other kinds of lymphoma, like follicular lymphoma or diffuse large B-cell lymphoma. Okay, it's going to be CD5 positive. Now, once this lymphoma enters the bloodstream, once these cells, these mutated cells enter the bloodstream, what is it called? We already said chronic lymphocytic leukemia. Now, both of these are the exact same disease. There's no difference. The only difference is their location. If it's inside of the lymph node, it's called SLL, small lymphocytic lymphoma. Once it enters the bloodstream, or once enough cells of SLL enter the bloodstream, we call it chronic lymphocytic leukemia. Okay. So basically, that's to tell the difference between ALL and CLL. ALL is going to be a child. ALL is going or CLL is going to be an elderly patient. Okay, and obviously you could get the cell markers and everything that can point you towards one or the other. Okay, but which one is positive for TDT, for example? Is it ALL or CLL? TDT. Who remembers that? ALL. Perfect. And why is that? That's because it's a cell marker of lymphoblasts. So lymphocytic lymphoma, they're not blasts, they're mature cells. Okay, perfect. Now, who can tell me what this is called? So just to give you a hint, it's the same thing we were just talking about. Smudge cells seen in CLL. So perfect. So these are smudge cells. Okay. Once basically just a cell type to be able to point out in CLL are smudge cells. This is what they look like. If you see this, pretty strong pointer to CLL. Okay. Okay. Now, uh, a lot of the diseases or a lot of the lymphomas that we talked about before could progress to this kind. So follicular lymphoma, for example, or CLL, they could progress to form this. What is this called? Diffuse large B-cell lymphoma. Perfect. So this is the most common kind of lymphoma in adults, or it's the most common kind of non-Hodgkin's lymphoma seen in adults. Okay. So what's the affected age group? Could be any age. Okay, younger ages or like children, once they have diffuse large B-cell lymphoma, it's associated with EBV. But older patients, it could be secondary or um, it could be progression of like CML, for example, or it could be progression of follicular lymphoma. A lot of these can eventually, progress to diffuse large B-cell lymphoma. What are these cell markers? So what are the cell markers? Perfect. So you could get CD10, you can get BCL2, and that's because obviously a lot of the times it's going to be secondary to follicular lymphoma. BCL6, CD19, and CD10, and also CD20, obviously. But CD10, and that's because again, it comes from the germinal center itself. Okay? Okay. Okay. Now, who can tell me what this is called? What's the diagnosis here? So you have this lesion on the jaw, and then African patients, and then you do a biopsy of the lymph node, and you see this Burkitt's, Burkitt's lymphoma. Perfect. What's the translocation? Okay, so it's 814. This causes an overexpression of c-Myc. Perfect. So c-Myc is a transcription factor. Okay, so when you get overexpression of tyrosine or sorry, of c-Myc, which is a transcription factor, you're going to get transcription of a lot of these proliferative, uh, you know, transcription signals that are going to cause proliferation of all these cells. Okay. What are the common organ involvements? And one of them you see here. So it's jaw and abdomen. Jaw is most likely associated with endemic areas. So you could get like a patient who, for example, immigrated from Uganda. This was a question stem that I just read. And they're going to have jaw involvement. Okay, so that's going to be Burkitt's lymphoma. Some of them can also have abdomen involvement. Okay. What's the morphology buzzword? So it's something you see here. Starry sky. Perfect. So starry sky appearance. And the reason why it's called starry sky appearances are because these things that you see here, these white spots, are the tingible body macrophages that I was talking about earlier in follicular lymphoma. So again, in follicular lymphoma, you don't see the tingible body macrophages. In Burkitt's lymphoma, you do see the tingible body macrophages. That's what's actually causing the starry sky appearance. Okay. So again, just because it's very high yield, I wanted to add a little bit more information. You're going to see in adolescents or young children, T4 814 translocation of c-Myc, starry sky appearance with interspersed tingible body macrophages, and it is associated with EBV. Okay, so that's what you also have to know. Burkitt's lymphoma, highly associated with EBV. Jaw lesion is endemic in Africa, pelvis or abdomen in sporadic form. Okay, and these are a few of the buzzwords. So translocation 814, starry sky appearance, very high Chi 67. I know that it's not mentioned anywhere in your slides, but I just wanted to bring it up because it is it is a buzzword that can pretty, it's very, very easy to know it's Burkitt's if you know what Ki-67 is. So Ki-67 is a cell marker of cell proliferation. And you guys know Burkitt's lymphoma because of the overexpression of this transcription factor. It's going to have a very high mitotic index, and they might say that too, very high mitotic index, or they might say very high Ki-67. Okay, and both of those are going to be buzzwords for Burkitt's lymphoma. Intermediate cells, so they're not like diffuse large B-cell lymphoma where they're large cells, or SLL where they're small cells. These are intermediate cells. Jaw lesion, abdominal mass, and EBV association. Okay. Okay. Let's read this together. This is another question that I got from Robbins. A 62-year-old man has had fever and a 4 kilogram weight loss over the past 6 months. On physical examination, his temperature is 38.6. He has generalized non-tender lymphadenopathy, and the spleen tip is palpable. Laboratory studies show hemoglobin, whatever, segmented neutrophils. A cervical lymph node biopsy specimen microscopically shows a nodular pattern of small lymphoid cells. A bone marrow biopsy specimen shows infiltrates uh, of similar small cells having surface immunoglobulins that are CD5 positive, but CD10 negative. Cytogenic analysis indicates T translocation 1114. So what's the answer? Perfect. So the answer is D. This is mantle cell lymphoma. Okay, what's the translocation and the target? We already know the translocation because of here. What does it overexpress? So it's cyclin D1. Okay, so the translocation is 1114, overexpressing cyclin D1, which you guys know is associated with your cell cycle. It's going to actually increase the cell progression from the G2 or the G1 to the S phase. Okay, so when you have overexpression, you're going to get very rapid progression through the cell cycle. Okay, what are the cell markers? We already brought them up, but they're CD5, cyclin D1, and CD20, but they're CD10 negative. Do you guys remember why they're CD10 negative? Very, very important. Why are they CD10 negative? No. So they are B cells. So this is again, this is a mantle cell lymphoma. I got an answer that was no B cell. No. That's because these are mantle cell lymphomas. Or this is a mantle B cell. So let me go back to the sorry. Let me go back to this picture here. Yeah. So again, we have the here, actually, let me go to this. We have here a secondary follicle. In the center, we have the germinal center. To the outside, right to the outside of the germinal center, we have the mantle zone. Okay, both of them are B cells. The only differences are the germinal centers are going to have different cell markers. When we talk, again, there are more differences, but just for our sake, what we care about, germinal centers are going to have different cell markers than mantle zone cells. Germinal center cells are going to be, where were they? Where was it? Did I not? I think I put it back here. Anyways, it's not important. Yeah. So mantle zone, or sorry, germinal center cells are going to be CD10 positive. Okay. That's because that cell marker specifically is for germinal center cells. Okay. Mantle zone cells, they're still B cells. That's why it's CD20 positive because that's for B cells, but they're going to be CD10 negative because they're not originating from the germinal center. They're originating from the mantle zone. Okay. Does that make sense? Okay. Let me Oh, here it is. Yeah. So CD10, germinal center cells. CD20, mature B cells. Okay. And CD19 as well. Okay. Let's move on. Um, okay. Yeah. So mantle cell lymphoma, cyclin D1, CD5 positive, CD20 positive, and cyclin D1 positive. Okay. Perfect. What about this one? 54-year-old woman has experienced nausea with vomiting and early satiety for the past 7 months. On physical examination, she is afebrile and has no lymphadenopathy or hepatosplenomegaly. CBC shows hemoglobin 12.9. Okay, an upper gastrointestinal endoscopy shows loss of the rugal folds of the stomach over a 4 by 8 centimeter area of the fundus, whatever, H. pylori, right? extensive mucosal and submucosal monomorphous infiltrates of small lymphocytes, which are CD19 positive and CD20 positive, but CD3 negative. After treatment of the H. pylori, hair condition improves. What is this? Perfect. Yeah. So this is multoma or a marginal zone lymphoma, not lymphomas, occurring due to what? Any chronic immune activation. So again, like I mentioned, you have the germinal center and then the mantle or the mantle zone and then the marginal zone, which is only active in high states of immune activation, such as Sjogren's syndrome or H. pylori. So a lot of the times you're going to get like the answer of marginal zone lymphoma is going to be associated with a case that has H. pylori or some sort of acute or sorry chronic immune activation like Sjogren um, or like SLE, for example. Okay, so multoma because it's mucosal associated. Do you guys remember that mucosal associated lymphoid tissue? That's in your abdomen that you see in gastric and gastrointestinal tissues. Okay, those are your your small lymphatic vessels or lymphatic cells. Okay, all right. So again, cell markers and translocation is 1118. Okay, just memorize this one, translocation 1118 for marginal zone lymphoma. All right. Now, what about here? So here you have an older patient who has these skin lesions that almost look like fungal infections. Okay. And then you do a biopsy and you see these cells. So what's the answer? Yep. So the answer is mycosis fungoides. And again, they named it this because when they first discovered it, they actually thought it was a fungal infection because it really does look like a fungal infection, but it's actually a T-cell lymphoma. Okay. So now we've moved on from the B-cell lymphomas, non-Hodgkin's lymphoma. Now we're talking about the T-cell lymphomas. Okay. All right. So the cell, you know what? Just give me 1 second. Let me turn on the lights. It's getting kind of dark. 1 second. Okay. So the cell origin, they're CD4 cells. Okay, CD4 plus T cells. What's the name of these micro abscesses? Does anyone know? This collection. Yeah, good. So that's Potrier micro abscesses seen inside of the epithelium, which is what's causing the skin lesions to form. Okay, and again, what does it initially present as? Skin lesions. So it starts in the skin, and then it might eat away at the basement membrane and then leak its way into the blood. Once it's inside of the blood or the leukemic phase, what is it called? Okay, I just saw that somebody had already answered it. Sézary syndrome. Good. Sézary syndrome. And you're going to see Sézary cells, which are cells with a nuclear cleft that one way to describe them that's commonly used in question stems are cerebriform. So you'll see cerebriform cells. I don't think there's any pictures of them inside of your guys' slides, but just know this word in case they ask about it. Okay, cerebriform, because it literally looks kind of like a brain. It has a little nuclear cleft. Okay, all right. Now, um, this one, I don't know if you'll get too many questions about anaplastic large cell lymphoma, but it's good to just go through it. This is another form of T cell neoplasm that's associated with a translocation 2-5. Okay, so just memorize this. It's going to be positive for CD30 and ALK1, so it's associated with rearrangement of the ALK gene on chromosome 2p23. Okay, large anaplastic cells. So just know the buzzwords T translocation 2-5 T-cell lymphoma, and the ALK gene on chromosome 2p23. And that'll probably be good enough for you to get all these questions right. And CD30 plus. Okay. Now, I wanted to touch a little bit upon the cellular origin of B-cell malignancies since we just went through all of the non-Hodgkin's lymphomas. So with B cells, what you get are these two things called the VDJ recombination and the somatic hypermutation. These are the ones that I want you to focus on right now. So early on in the maturation process of a B cell, it's going to undergo something called the VDJ recombination, where it's basically going to provide variance and differentiation of the B cells to in order to be able to react to many different kinds of antigens, okay? And somatic hypermutation is where it kind of gets specific to one antigen. Okay, so you're going to have a germinal center B cell, and obviously you can have this germinal center B cell going around and having an immune reaction to every single antigen it comes across, because then that's how you get autoimmunity. So it's going to undergo something called somatic hypermutation, where it's going to have like it's going to be very, very specific to one antigen. Okay, it's only going to respond to this specific antigen. Okay. Um, Deficiencies or defects in the VDJ recombination process is going to lead to follicular and mantle cell lymphomas. And the somatic hypermutation, any mutation that goes on in somatic hypermutation, that's what gives you the Burkitt's lymphoma. Okay. So again, these are just things that you have to memorize. Multiple myeloma, I think I'm gonna, I think you guys are gonna have another session on that soon. So we're done with the non-Hodgkin's lymphoma. Now we're going to go into the Hodgkin's lymphoma and the difference. Again, I said before that the main difference between the Hodgkin's and the non-Hodgkin's lymphoma are the Reed-Sternberg cells. Okay, and that's because the Reed-Sternberg cells in Hodgkin's lymphoma are the true cancerous counterparts of this lymphoma. They're going to secrete all these cytokines. They're going to recruit these reactive lymphocytes and reactive cells. They're going to form this mass, and they're going to have the constitutional symptoms. Okay. The constitutional B symptoms, which are things like night sweats, weight loss, low-grade fever, fatigue, all of that you're going to see in both Hodgkin and non-Hodgkin. So the main difference is going to come down to biopsy and just like the clinical or sorry, the morphological manifestation of Hodgkin's and non-Hodgkin's. Okay. Usually, like I mentioned before, non-Hodgkin is going to be associated with a worse prognosis, and that's because there's multiple lymph nodes involved, extranodal involvement, and you have the Waldeyer's ring involvement. Hodgkin's going to have a better prognosis usually. Again, some forms of Hodgkin's lymphoma are associated with EBV, more so than non-Hodgkin's. EBV is associated with a few non-Hodgkin's lymphoma. Like I mentioned, there's the diffuse large B-cell lymphoma, Burkitt's lymphoma, both of them are associated with EBV. Hodgkin's, it's more, it's usually only associated with EBV. Okay, and again, these Reed-Sternberg cells, they're going to be CD15 and CD30 plus. Okay, they're not going to be CD20 positive or CD20, CD19 positive. They're going to be CD15 and CD30 positive. Okay, and they're characterized by this thing called the owl eye nucleus. Okay, so the bilobed nucleus is going to look like, it literally does look like an owl eye. Okay, so these are called owl eyes. Okay, that's how you know what a Reed-Sternberg cell looks like. These are the different kinds of Reed-Sternberg cells that we're going to get into in a minute. But do we have any questions about non-Hodgkin's lymphoma so far? Are we all good? Again, perfect. There was one that I discussed earlier on when I talked about ALL, and that's the lymphoblastic lymphoma, usually seen as a mediastinal mass in teenagers. And it's usually because of T cell origin. Obviously, that's associated with the worst prognosis. That's the same exact disease as ALL. The only difference is the location. So um, if it's in the thymus, you have the thymus involvement, then you know that it's lymphoblastic lymphoma. Once it enters the blood, or if it's in the blood, then that's how you have ALL, which is acute lymphoblastic leukemia. Okay, perfect. So the main thing that I want you guys to really, really try hard to understand and memorize is just understanding rather than memorizing, sorry, understanding these. If you understand these, like if you know that my CD10 is going to be my germinal center, CD19 and 20 and 21 are the actual mature B cells, 1, 3, 5, 4, they're going to be T cells. If you understand that, then you'll be able to easily know you know, what lymphomas or what leukemias or what cancers the question's asking about. Okay? All right. Let's move on to our Hodgkin's lymphoma. One sec. This is going to take a minute. Okay. Now, who can tell me what the diagnosis is here? This is a 27-year-old female, and she had some She has a mass in her anterior mediastinum, and you do a biopsy, and this is what you see. So what is this called? Perfect. So this is nodular sclerosis, okay, which is the most common kind of Hodgkin's lymphoma, by the way. So nodular sclerosis, and obviously you know from the immediately by looking at the picture, you know that it's nodular sclerosis, obviously because you see these nodes and you see sclerosis all around it. So you get these bands of fibrosis, okay, and this is pretty specific for nodular sclerosis, okay. What's the affected population? Usually, it's going to be young adolescent females, and the location is going to be mediastinal. Usually it's more anterior. You might get posterior mediastinum, okay, but it's in the mediastinum. Cell markers. Who can tell me cell markers of nodular sclerosis? Perfect. CD15 and CD30. Obviously, because this is a Hodgkin's lymphoma, so we're going to see Reed-Sternberg cells. Um, what about the prognosis? Is it good or bad? It's actually excellent. It's a very good prognosis. They're very responsive to chemotherapy. Okay. Now you take one of these cells in nodular sclerosis and you zoom in on them, or sorry, let's solve this question first. A 22-year-old woman has experienced dyspnea for the past 2 months. On physical examination, she's afebrile and normotensive. Inspiratory wheezes are noted on auscultation of the chest. Okay, so there's something there that's compressing her airway. A chest CT scan shows an 8 by 10 centimeter posterior mediastinal mass that impinges on the trachea and the esophagus. Okay, blah, 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 blah. Multinucleated cells, prominent nucleoli, CD15 positive, lymphocytes and macrophages separated by dense collagen bands. Which of the following cells is most likely to be seen? Who can tell me what the answer is? Perfect. So D. These are lacunar cells. Okay, so this is what I was saying before. You zoom in on one of these cells and you'll see something that looks like this. So this is a lacunar cell. Okay. So two things that I want you to remember for or actually technically three things for nodular sclerosis. Reed-Sternberg cells, which you'll see in any Hodgkin's lymphoma, or most of them. Lacunar cells and your bands of fibrosis. Okay. And in a younger woman in a mediastinal mass. So that's your nodular sclerosis, most common. Okay. What about here? What's the diagnosis here? Again, do you see this? Reed-Sternberg. But you're looking at something else too. There's a different kind of cell in here. Mixed. Perfect. So this is your Hodgkin's lymphoma mixed cellularity subtype. Okay. Now, what determines whether or not it's mixed cellularity? They'll tell you most of the time that there's going to be different cells in there, like basophils and things like that. But eosinophils is what I really want you to remember. Okay. If you see eosinophils, and you'll be able to see it just by looking at the picture. If you see eosinophils, pretty much, and the Reed-Sternberg cells, you'll know pretty much right away that it's mixed cellularity. Okay. What is it associated with? It's associated with an infectious organism. Perfect. It's associated with EBV. Pretty strong association too. Okay. And the cell markers, again, just like we mentioned, they're CD15 and CD30 positive. Perfect. Okay. What about here? What's the diagnosis here? Just to give you a hint, these are not really Reed-Sternberg cells. Yeah, perfect. So this is the nodular lymphocyte predominant type. Now, we just went through all of the classic Hodgkin's lymphoma. Okay, or we're about to right after this. This is a non-classic Hodgkin's lymphoma because it doesn't actually have any Reed-Sternberg cells. Okay, instead it's going to have these cells that look like Reed-Sternberg cells, but they're going to be negative for CD15 and CD30 cells. So what are these cells called? We call them popcorn cells. Okay. And what are their cell markers? So they're not CD15 and CD30 positive. So they're CD20 positive. Okay. They are of B cell origin. Okay. Are there any Reed-Sternberg cells present? No. So they're CD30 and CD15 negative. Okay. Now, the last two kinds that I want you to know of Hodgkin's lymphoma are the lymphocyte rich and the lymphocyte depleted. And this goes back to our discussion about what is a Hodgkin's lymphoma. So the reason that it has a better prognosis is that the actual cancer itself or the actual defect is in the Reed-Sternberg cells, and that doesn't take up most of the mass. Most of the mass is taken up by the reactive cells that the cytokines released from the Reed-Sternberg cells is going to gather. Okay, but in lymphocyte depleted subtypes of Hodgkin's lymphoma, it's going to have a worse prognosis, and that's because there's not a lot of reactive cells that are going to gather in that area. It's actually going to be mostly the Reed-Sternberg cells. Okay, so the simple concept is that the more Reed-Sternberg cells you have, the worse prognosis you have. So if it's lymphocyte depleted, that means there's not enough lymphocytes there. It's mostly Reed-Sternberg. That's a worse prognosis. If it's lymphocyte rich, that's the better prognosis. Okay? That's what I want you to know. Okay? Do we have any questions about the Hodgkin's lymphoma? Okay, perfect. All right. Okay. Who can tell me what this is? What's the diagnosis here? You have this mass on chest X-ray, and then this person also has some back pain, and they also have some sensory deficits in their lower limbs. Perfect. So it's malignant spinal cord compression. Perfect. Caused by a metastasis of a cancer to the spinal cord, and that's going to cause compression of the nerve, and it can cause some neurological deficits like sensory deficits, some motor deficits in the lower limbs. Okay. What's the best treatment? Perfect. So it's bed rest, dexamethasone, and decompressive surgery. But I want you to remember dexamethasone because obviously bed rest and decompressive surgery are a given. Okay. Now for this lecture, there's not much that I want you to remember. I just want to talk about tumor lysis syndrome because I think the rest is pretty self-explanatory. So tumor lysis syndrome is basically a complication that you might get, and it's very highly associated with leukemias and lymphomas. So it's not really as associated with um, like solid tumors, like for example, a lung carcinoma or a uh, colon cancer, for example. It's highly associated uh, with blood disorders, blood cancers. Okay, so what happens is that once you get tumor lysis, once you get these cells that are going to die off, they're going to release a bunch of stuff in the to the bloodstream. So mainly, they're going to release a lot of potassium. They're going to release a lot of phosphates, and they're going to release a lot of uric acid. Obviously, the uric acid and the phosphate are a given, and the potassiums are a given because they're very, very in high concentrations intracellularly. Once you get a lot of phosphates that's released from these cells, all of that phosphate you guys already know from your physiology is going to take up all that calcium, leading to hypocalcemia. Okay? But I just want you to remember these main four things. You're going to get hyperkalemia, hyperphosphatemia, hyperuricemia. Because of the hyperphosphatemia, you're also going to get hypocalcemia. So everything is high except for the calcium. The calcium is low. Okay? And then the symptoms and the complications that you would get are all secondary to these electrolyte abnormalities. So the hyperkalemia is going to cause mostly is going to cause arrhythmias and ECG changes. Okay, it could cause muscle weakness, but that's not as specific as the ECG changes. The low calcium is going to cause seizures and tetany, and also the ECG is going to contribute to the ECG changes. Okay, the phosphate is going to cause the calcium phosphate crystals, and the uric acid is going to cause the uric acid crystals. Both of them are going to cause acute kidney injury. So these are the main symptoms and complications of tumor lysis syndrome. Okay, so it's an oncological emergency triggered by massive tumor lysis, cell lysis, seen most often with lymphomas and leukemias. Um, Release of potassium, you're going to get hyperkalemia, release of phosphate, hyperphosphatemia, and hypocalcemia, and high uric acid levels that's going to contribute to your acute kidney injury. Okay, how do you prevent it and treat? You prevent it with aggressive hydration, allopurinol, and rasburicase. So allopurinol is your xanthine oxidase inhibitor. It's going to prevent formation of the uric acid in the first place, and rasburicase is going to promote the excretion of uric acid in the urine. Okay, all right, perfect. And the last concept, inshallah, that I want to talk about today is your leukopenia and leukocytosis. The entire lecture can be summed up in this image, to be honest. Okay, so you get you can get of anything that's when you have too many cells in your body, you're going to call that philia or cytosis. And too little is going to be penia. Okay, so neutropenia is going to be caused. There's first of all, there's two different kinds of neutropenia. There's congenital neutropenia and acquired neutropenia. There's also something called febrile neutropenia, which I don't know if you guys had a lecture on yet, but febrile neutropenia is very, very severe neutropenia. Usually, uh, it's going to be less than 500. For the absolute neutrophil counts, it's going to be less than 500. And when you get that, you're very prone to invasive infections, things like aspergillosis, things like candidiasis, or like fungal infections like in the bloodstream. That's extremely associated with neutropenia, and also hospital-acquired infections like Actinobacter, for example, very highly associated with neutropenia. Okay, also can be caused by splenomegaly or hypersplenism, chemotherapeutic drugs, and bone marrow failure, obviously because you can't produce these neutrophils. Now, neutrophilia is going to be caused by any sort of infection, tissue destruction, some malignancies. Corticosteroids are going to cause also neutrophilia. This is very important for you to know. And that's not because they're increasing the production of neutrophils. That's because they're actually going to inhibit the demarginalization of neutrophils. You guys know your neutrophils are just they're just flowing in your bloodstream. And at the site of an active infection, they're going to exit the bloodstream and sort of, you know, go into the tissue. Corticosteroids are actually going to prevent that from happening. So they're going to inhibit the demargination of neutrophils and their extravasation into the tissue. Okay. Physiological and stress and physical agents and metabolic disorders can all cause neutrophilia. Okay. Eosinophilia, I just want you to know it's mostly for hypersensitivity and parasitic infections. Okay. So things like type 1, like allergies, for example, allergies, asthma, you can get eosinophilia. Parasitic infections, pretty much all of them can cause eosinophilia. Certain drug therapy, myeloproliferative disease can also cause eosinophilia. Eosinopenia is usually seen with a bacterial infection and ACTH administration. Okay. Now, monocytosis, you can see bacterial infections, so like TB, for example, recovery phase of neutropenia, subacute bacterial endocarditis, and myeloproliferative diseases. So you guys are seeing a pattern here with these myeloproliferative diseases, right? And then monopenia with hairy cell leukemia and corticosteroids. Okay. Lymphocytosis and viral infections. So a classic example would be mononucleosis, for example, because of EBV, you would get lymphocytosis, albeit the lymphocytes are atypical lymphocytes, but there's still lymphocytosis. Some fungal parasitic infections can cause lymphocytosis. Rare bacterial infections, drug sensitivity, and immunological disease. Lymphopenia, I mainly want you to remember HIV and AIDS. Okay, HIV and AIDS can cause pretty severe lymphopenia that can sort of allow you to be more vulnerable to diseases and to infections that would otherwise be mild. They would be very severe in these cases because of the lymphopenia. Okay? All right. This is the end of our crash course. Does anybody have any questions before we end it? I think we took up just under 2 hours, so I think it's pretty good time. Okay. In that case, thank you all so much for listening. Please scan this code. Let me know how I did. And yeah, best of luck for you guys' exam, and thank you.